Hi everyone, my name is Erin Doucet. I'm an occupational therapist and a certified lymphedema therapist at the Ward Therapy Center. And today I'm going to be talking with you about what lymphedema is, how you get it, how it's treated. I find, I treat this on a daily basis, and I find that unfortunately it's either underdiagnosed or diagnosed too late, and people don't really receive treatment until in the prime time. They receive it really when it's too late, and it's just going to take longer to get better. And so I kind of want to do some education about why it's important to get early treatment, how we treat it, and the benefits of it. Okay, so that's just our therapist, and this talk is on lymphedema, and those are my credentials. So first we go with what the lymphatic system is. A lot of people really don't know what it is. It's not taught too much, and it's definitely not part of our normal, it's not as complex like the cardiovascular system or anything. So the lymphatic system, in this picture you can kind of see all these green lines. Those are all the lymphatic vessels, and we'll go over that a little bit more. So the lymphatic system is not a closed system. Unlike the cardiovascular system, which has a specific route that it takes, the lymphatic system doesn't have one quite as definite as that. It does have a route how it gets back to the heart, but you have these capillaries and vessels that span the whole body, and the fluid can be moved in between them. So it's not a direct path. And it doesn't contain a central pump. Just like the cardiovascular system contains the heart, and that's what pumps the blood throughout the body, the lymphatic system doesn't have that. There's not a central pump. So it does rely more on muscle pump, compression, moving the skin, and all of those things. And the purpose of it, it drains substances that cannot be reabsorbed by the blood system. And then it also holds and circulates lymphatic load. So the lymphatic load is what makes up that lymph fluid. It's composed of water, protein, cell fragments, and fat. And so when you're looking at the cause of lymphedema, it's that fluid sitting in the tissues, and it's the protein that can't get back in. And we'll go over that a little bit, but it just circulates this fluid throughout the body, and that just helps with our immunity, helps with healing, and everything. So the anatomy. There's four parts to the lymphatic system. There's the lymph plexus, which is just like basically the spider web of lymphatic vessels that span the entire body. And this is good because this means that lymphatic system, that fluid can go anywhere. And this is what we really play on. And it also contains lymphatic capillaries, which if you look at this picture, it's these ones right down here. So what those are is that what collects the lymphatic fluid. That comes right from the lymphatic vessels, and that's what initially picks up that fluid, and it moves it into these lymph collectors, and that gets closer. It's right up in here. Those lymph collectors, that's where the fluid starts getting pushed. And then you have this lymphatic nodes. Lymph nodes are they're just areas in the body where all the lymph has to travel through before it can be absorbed. It filters out good stuff, filters out bad stuff, and it's just where all the filtration happens. So almost all of the lymph fluid in the body is returned to the left venous angle, and then is returned to the circulatory system. So we're always really trying, when we treat it, we're moving that fluid towards that area to be drained back into the circulatory system, to either be pumped out through the blood or drained through the kidneys. So now I'll talk a little bit about the lymph nodes. Everyone's kind of heard of these. You might not know much about it, but this is a very big part of treating, because you're always pushing that lymphatic fluid in these congested areas towards healthy lymph nodes and away from congested lymph nodes. So in the body, we have three lymph nodes. We have our axillary, which are right in that armpit area, and these drain the upper quadrants and the upper extremities. So the quadrants of the chest and both arms. Then you have your inguinal lymph nodes. These are in the groin area, and these drains the legs, the lower body quadrants, and the genitalia. And then you also have the cervical lymph nodes, which are right in here. So like when you get sick and you kind of feel like your throat's swollen, that's what you're feeling, those cervical lymph nodes. And that drains the head and the face. And like I said, all of this drains back into that left venous angle, which goes back into the heart. So there's two parts of the lymphatic system. There's the superficial and the deep system. So the superficial system is suprafascial, which just means it's above the fascia. So it's very superficial, and it sits right underneath the skin and the fat, which means it's easily manipulated, so it's a really good thing. And this drains the lymphatic load of the skin. And this is mostly what we see. The majority of lymphedema involves the superficial system. So whenever you see that swelling, you might think is really deep and you want to really get deep in there and treat it, but it's not. You need a light touch to treat it. Then there's the deep lymphatic system. So this lymphatic system is subfascial. So underneath the fascia, the muscle. This drains everything but the skin. So the muscles, the tendons, the bones, everything like that. We don't have lymphatic system in our eyes and our teeth, the dentin, but it's everywhere else. And so the deep system drains all of this. We don't see this very often. This is when you're treating the majority of lymphedema cases, like stated earlier, it's almost always the superficial system. The deep system, when that becomes compromised, you're looking more of like a compartment syndrome, which requires, as we know, more emergency surgery. It's not so much just drainage like I treat. So the pathways. To treat lymphedema effectively and to get results from it, you have to treat over specific pathways, and these are all dependent upon what areas are infected. If you're not treating over these pathways, you might get a few results, but you're really not going to get the best. So we're going to kind of go over that. So first of all, we have in our body what we call watersheds. So these are these yellow lines. They can go divided up into left and right and up and down. Here at the shoulder, sternum area, and then kind of midway at the waist. So these lines separate the bodies into territories. And so what happens is, whenever you're having swelling, it's going to stay in those territories. The good thing about lymphedema, if there really is a good thing, is it's not going to travel. So if you have swelling in the right arm, and you have never had anything done in the left arm, no lumpectomy, nothing like that, it's not just going to get in your left arm. It's not going to go to the right leg. It's going to stay in that area. So on one hand, that's a good thing. You can treat the one area, and it's just easier to, worry about, instead of thinking, maybe it'll go to my left arm, maybe it'll go to left leg. It's going to stay in that area. And so in your body, you have all these collectors with those lymph floaters we talked about. These run from the watersheds into the lymph nodes. So if you're looking, let's say this is a watershed, all of the collectors are running up the chest, into the armpit axillary area, and up the arm into that axillary area. So then we also have what we call anastomosis. So there's two types. There's intraterritorial, which these collectors are in the same territory. This is how fluid is moved between each other within the same territory. Then you also have what we call interterritorial. So these are connections between two territories. So if you look on the picture, you have that left and right quadrant, and you can see that little arrow kind of around the mid-chest area, and then there's one right above the groin area. These are the anastomosis of the chest. So what happens is these connect the territories. There's a few capillaries right in that area, and what we can do is we can open it up, and we can open those anastomosis and those channels to move fluid from the impaired area to the healthy area. Because if you're looking at treatment, if you had a lumpectomy, so this is where the axillary nodes are impaired, so you have lymphedema in your left arm, we're not going to shove more fluid to it. It's just going to overwhelm it. The arm's going to get more swollen. It's not going to do anything. We need to move it over to the healthy area, reroute it, move it to healthy lymph nodes to be drained. And we use those channels to do it. And then, so we'll go over the locations of them. So there's 6 in the body. So the first one is, let's figure AAA, or your anterior axillary, and that just goes here to here, axilla to axilla. They're all named based on where they're going to. So then the other one is your AII, anterior interinguinal. So groin, like right hip area to left hip area. And then you have your axilloinguinal or your inguinal axillary. This is the same channel. It just depends on where you're going. So if you're moving fluid down, axilloinguinal, both sides, or if you're moving fluid up, inguinal to axillary. Coming up this one, same, both sides. It's the same channel, just depends on which way you're going. Then you have those same channels on the back. So you have your PAA, so on the back from the shoulder blades basically, and then your PII, which goes hip to hip. And those channels can go back and forth. It's not a one-way channel. It just depends on how you open it. The AI or the I is only on the front. So you have to know these channels when you're treating to open up those pathways so you can move that fluid. Like I said, you don't want to just move it in the same area or move it to a congested area. You need to move it to a free area to really move that fluid. So that's the lymphatic system, the anatomy of it. So let's talk over like how lymphedema is caused, what is it, how does someone develop lymphedema? So what is lymphedema? Lymphedema is an abnormal accumulation of protein and water in the interstitial spaces. Like I said, that's what's in that lymphatic load. And it's the protein that causes the problem. The water is small enough to go in between to diffuse back and forth in the vessels. The protein can't. It can't get back into the vessels to be picked up, and that's what causes that building up of fluid. This is also why like taking like a Lasix or a water pill doesn't work enough, because they'll drain the water, but the protein's still staying in there. And so unless you move the protein, you're not really getting anything. You might get a little bit of decrease in swelling, but not significant, and you still have the problem. And so in worldwide, there's 140 to 250 million cases. Most of these cases are worldwide. The number one cause is a parasite called filariasis. So what that is, it's a parasite that once it bites you, it lays eggs in the lymph nodes, and those eggs grow, and it causes those lymph nodes to become congested, developing lymphedema. So that's worldwide. There's 2 to 3 million cases of secondary lymphedema in the U.S. The number one cause is breast cancer. And there's hundreds of cases of primary lymphedema, and we'll go over the difference between those. And there's also no cure for lymphedema. There's a few surgeries, medicines, things out there right now, but nothing that's like the number one treatment of it at the moment. So there's really just no cure. It's chronic progressive, so it's chronic. So once you have it forever. You have to do lifelong management, and it's progressive. So you have to treat it for it to get better. If you just leave it alone, it's not going to get better with it. It's only going to get worse and worse. So it does require treatment. So the types of lymphedema, there's 2 types. So the first one's primary. This is something you're born with. It's congenital, most likely, normally. It's a malformation or dysplasia of the lymphatic system. So when you were born, the person who has this, the lymphatic system just didn't develop properly. There was a malformation, something happened, that it just isn't working the way it needs to be. This is almost always develops in the lower extremities. Most people develop it between 0 and 5 is one, or by the time they're 35. So if you develop it when you're 50, most likely it's not a primary. Something happened to cause it. But if you develop it when you're 2, it's primary. You were born with it. So the second type is secondary lymphedema. Like I said, this is caused by an insult or an injury to the lymphatic system. So you were born with a perfectly fine lymphatic system, you were doing fine, and then something happened and caused it to now not work properly. And this could be surgery, like a mastectomy, a lumpectomy. You're taking out lymph nodes, you're taping out parts of the lymphatic system that don't regrow. Those lymph nodes don't regenerate. Capillaries can, but if there's a lot of scar, it can't regenerate through them. So anytime you do a surgery, remove a lymph node, even one, you're causing the lymphatic system not to work as well. Radiation kills everything all the way down to the bone. So it goes through the muscles, it goes through the nerves, it goes through the capillaries, everything. So you can see lymphedema develop from that. Trauma to the area. If you take a blunt injury over an anastomosis, a channel, a watershed area, in these bottleneck areas, these really important areas, it can cause actual damage to the capillaries that don't regenerate. Now you develop lymphedema. Cancer, like we said, that could be prostate cancer, can also cause lower extremity lymphedema, so it's not just breast cancer. So an infection or inflammation to the system can also cause lymphedema to develop. So I'm going to kind of just touch on these charts. These are kind of important just to understand the difference in lymphedema versus edema, and even just within lymphedemas. So this very top part, let me explain what they are, some of the terms. So this bar on the left, which is on this top picture, is the really tall one, that's your transport capacity. So that's just how much fluid the lymphatic system can remove from the body when it's working at max. That's how fast it can go. Then you have this little tiny bar right to the right of it, that's your lymphatic load. So that's just how much lymphatic fluid you have in your body. And then you have all that space in between. You can see it says FR, that's your functional reserve. So that's basically your backup. So if you do have a little bit increase in lymphatic load and your system's working normally, you have all of that room to not see any problems. So the top picture is a normal system. Transport capacity can work really, really hard. There's plenty of backup to remove the lymphatic load, and you don't have that much. So let's go down to this dynamic insufficiency. So what this is, you can see the transport capacity is normal. It works as high as it would normally would. But then you have this lymphatic load, it's higher, it's surpassing that transport capacity, and that's when you start seeing fluid. So what this means is your lymphatic system is working normally. There's no problem with it. You just have too much fluid in the body that the fluid amount is overwhelming how much the system can pick up, but it's not damaged. So it's dynamic. There's just a imbalance between the numbers. And when you see this is when you see edema, just swelling like after you sprained your ankle, jammed your finger, any just regular swelling. This is not treated with manual lymphatic drainage, what I go over and what I do. They're not indicated for this. These people will do better with the basic rice, ice, compression, elevation. So then you have this mechanical insufficiency. So this is someone, this picture right here. So this is the middle picture. This is someone whose system is not working as well as it was, as well as it's supposed to be. It's not working normally. You can see that transport capacity on the left, it's fallen way below. So this just means their system isn't working well. And then you have the lymphatic load. There's just a teeny tiny bit. So if it stays at this level, then you might see a little swelling here and there, but it's really not bad. But it is important to know that their system is not working. So any kind of increase in lymphatic load will increase lymphedema, which is if you go to the left, that's what you see, that combined insufficiency. Transport capacity far below normal, it's damaged. Lymphatic load is high, it's definitely elevated. This is when you start to see the swelling. The body, you can just see that lymphatic load is so high, the system can never get rid of it in time. Even if it's working at its max speed, it's just pulling, and it can't get rid of it. So that's when you see that limb size growing. This is true lymphedema. It is important to know, we'll go over that dynamic insufficiency can turn into a mechanical insufficiency. If the lymphatic system is working at max all the time, just like everything else, we're not meant to work at our full capacity 24 hours a day. So if this happens over a long time, that system will start to break down, kind of like a car. If a car is working at max capacity every single day, putting all these miles on it, eventually you're going to have problems. It's going to start breaking down. The lymphatic system does the same thing. This turns into a mechanical insufficiency, and we'll go over in an instance where that happens. So that's how lymphedema develops and occurs. So now we're going to go over the stages of lymphedema. So there's 4 stages. The first one is stage 0. This is your pre-stage or your latency stage. You don't see any swelling in this stage. You might not even know you would have lymphedema in this stage. This stage applies to only people who have secondary lymphedema from breast cancer, mostly. So, like I said, anytime you remove a lymph node, a lumpectomy, a mastectomy, anything like that, radiation, you've damaged the lymphatic system. So it's already not working as well as it should have been. So you're always at risk for developing lymphedema, which is why you're in this latency stage. You always have the chance of developing it. Lymphedema can occur the day after surgery, or it can occur 50%, get it within 5 years of surgery. You can also get it within 20 years of surgery. There's no time period where you're out of the clear. You're rarely never out of the clear, so you always have to take these precautions. Second stage is stage 1. So stage 1 is what was very mild or reversible. In this stage, you don't see any skin changes. Really, all you see is that the area affected is just a little bigger than normal. These people who have this, it might recede at night. They wake up, the limb looks fine, the area looks fine. Throughout the day, gravity happens, it swells up, they go to bed, cycle repeats. These people who have this, you're able to completely remove the swelling with complete decongestive therapy, which is what I'll go over. I'm going to call it CDT for short. You're able to get rid of it. Just a few weeks of the drainage technique, compression wrapping, and then management, that limb size will reduce to normal. This is the optimal stage to treat lymphedema in. Unfortunately, it's not the stage that we normally treat in. Stage 2. So stage 2 is spontaneous irreversible or chronic irreversible. You're not going to see that decrease in swelling overnight with this. It's always going to be swollen. So this stage is defined by fibrosis. So what that means is when fluid sits in the body for a while and gets stagnant, it just starts to get hardened. And it feels like little rocks or little hardened areas underneath the skin. This is fibrosis. So in stage 2, that's what you're going to see. So in stage 1, the skin feels just very spongy, very soft. This is stage 1. You might have some pitting where you put your finger in and it leaves the imprint, very soft. Stage 2, you're not going to see that. It's more brawny, it's more spongy, kind of boggy because of that fibrosis. So the amount of limb reduction you see in stage 2 is going to be defined by how much fibrosis they have. The more fibrosis, the less limb reduction you're going to see right off, because it's going to take longer for that fluid, the hardened fluid, to break up. If they don't have a lot of fibrosis, they have mostly soft fluid with just a little here and there of fibrosis, it's going to drain pretty quickly. And fibrosis will break down over time with compression wearing, but it takes a long time. You're not really going to see it in the clinic, because when you're treating lymphedema, you really don't normally treat for 5-6 months. You really normally treat about 2 months or so, depending on how 4 weeks to 8 weeks, depending on how severe, and then you kind of transfer to a home maintenance program. And then stage 3. Stage 3 is this lymphostatic elephantitis. So the most severe stage. And this stage is characterized by skin changes. So funguses, ulcers, cysts, papillomas, hyperkeratosis, deepening of those skin folds. It's almost all fibrosis. There's really not a lot of soft fluid. Weeping, which is fluid being expelled through the skin, so that they might say their legs feel wet. That's weeping. And you'll see a little bit of fluid reduction in the clinic, and over time you will see a decrease in limb size, but it's going to take a long time. It's all with that compression and that fibrosis having to break down, and they'll probably never have, a normal, quote unquote, normal limb. It's always going to be bigger. So when they come to the clinic for an evaluation of lymphedema, these are all the things that I'm looking at. I'm looking at how I take some measurements at different areas, circumferential measurements, to measure the limb now, and it's also how I track progress. And then I'm also looking at, do we see any skin changes? Are they having pain? When did this set in? How long have they had lymphedema? Does it hurt when they do this? All of these different things, and that kind of tells me what stage they're in, first of all, and kind of what I'm treating. Am I treating a true lymphedema? Is it caused by something else? We'll go over that in a little bit. And it's also very important to know that the stage of lymphedema is not defined by how big the limb is. We take these measurements, they're important for progress, for garment measuring, all of that, but it's not how we characterize the stage of lymphedema. It's all characterized by this fibrosis and skin change. So you can have someone come in with this huge leg, huge, but it's super soft, there's no fibrosis, there's no skin problems. They're stage 1, which is great. But people often think the bigger it is, the worse stage, which is probably mostly correct, but that's not how we decide what stage they're in. And knowing the stages are really important for really just setting up patient expectations. We don't want to have someone stage 3 come in with these wounds and tell them, like, oh yeah, I'm going to get you back to normal. That leg's going to be small like the other one in 2 months. It's just not going to happen. And it's really important that when you're doing this education with patients, you give them reasonable expectations of what they're going to get out of therapy. And that's with anything, but really with lymphedema, because you do see there's such a emotional, social, psych component to it, because they're dealing with this just misshapen limb, they're embarrassed, all that. So you really want to know that you're setting them up for success and what to expect, and that they trust you, and that you're getting the best, that they're getting the best treatment from what you're doing for them. So those are the stages of lymphedema. So now there's other things that can cause lymphedema besides the most common, which is cancer, and I'm going to go over those. So the first one is chronic venous insufficiency, or CVI, and I treat this a lot. I really see this very common. It's very common. So what happens is it's an insufficient venous return due to the ineffectiveness of the veins and muscle pump. So what happens is, over time, especially you see it a lot with people who stand a lot, so nurses, teachers, I see a lot of offshore workers who develop this, doctors, anyone who stands most of their day. Your veins are trying to, especially your lower legs, you're trying to pump that blood back and that fluid back to the heart to get it recirculated, but those veins are weak, and so when those valves come up, they kind of prolapse a little bit, and some of that fluid comes back down, and this causes pooling of the blood. So that's for the venous system. And the lymphatic system, it helps in. It develops a safety factor, which is a backup of the body, that whenever you have a lot of swelling, the lymphatic system just kind of helps out to get it out quicker. So if you're having a ankle sprain and the lymphatic system helps out for a couple of weeks for the inflammatory period, great, no problem. It's small. It's a small window of time. But CVI is a long time. These people who've had it, they've had it for years and years and years. So if your lymphatic system is working, like I talked earlier, max capacity all day, every day, eventually it's going to break down. And this is how that dynamic insufficiency turns into a mechanical insufficiency. So now, they didn't have any damage directly to the lymphatic system. But because the lymphatic system was working too hard, it has broken down, and now it is damaged. And so now not only do they have a CVI, a vein problem, they do have lymphedema. And you have to treat both. If you only treat the vein problem, but you never treat the lymphedema, they're always going to be swollen, and vice versa. So it's really important that they're getting a full treatment so that they're going to actually see the reduction in limb size. And this is almost always in the legs, as in it's always in the legs. So then you have what's called lymphedema. And so this results from lipedema, which is this Lipedema. It sounds similar, but it's different than lymphedema. So while lymphedema is an inflammation due to the lymph fluid, lipedema is due to excessive fatty deposits in the legs. So these are just people who, you mostly see them mostly always in the legs. Legs are really big, and they may have a smaller upper body, but just very large legs. It's most often congenital, so it runs in the family. Their mom might have had big legs, or grandmother had big legs. That's kind of what you hear patients say. But they don't really know the cause of it. But it's just increase of fat deposits. So what happens is technically they don't have lymphedema, like I said. But over time, those fat deposits press on lymphatic capillaries. Like I said, they're right underneath that fat layer. So they're just pressing on it, compressing, and they can kind of get coiled and kinked. So now what happens is that transport capacity we talked about, it's below normal. So it's just not working as high as it needs to be. So if it drops below the lymphatic load, so lymphatic load's here, transport capacity is here, you're now going to see increase in swelling. And this is more than dynamic insufficiency. So for these people, CDT, which I'm going to go over again later, is not indicated. They're going to get the best with just compression and maintaining a healthy weight. It's really important. Education with these patients about maintaining a healthy weight, which is really hard for them because, they'll say, no matter what I do, how much I eat, how much I exercise, I'm always, fat, just because of their condition. But it's really important for them to stay as like a healthy weight for them as possible to prevent more damage to the body and just for your health, just health-wise. So then trauma, so it can be inflammation. This can be inflammation to the cells, the tissue, the lymph node damage, or actual blunt trauma to the area. In your body, I didn't really go over, but we have these bottlenecks, so it's on the inside of your elbow and on the medial aspect of your knee. These are bottleneck areas. So in the arm, all of that fluid has to go through this area. So if you got hit really hard right over that area and it caused really bad bruising, contusions, you probably damaged your lymphatic bottleneck right there. So you're now, not to say you will develop it, but you could and you might, because now those capillaries are damaged. It all depends on if they've regenerated and can heal. So direct trauma can cause lymphedema to occur. So then we also have traumatic edema. And while this is not lymphedema, we can use the lymphatic system to help out. So like we talked about, the lymphatic system has that safety factor to assist with just treating lymphedema. And this can be after blunt trauma, post-surgery, so things that post-surgical where you really need to get that edema down to get measurements and get progress, such as like a knee replacement, finger injuries, we see a lot of tendon injuries, that's fractures in the digits. That swelling is preventing motion, and we know as clinicians that the longer that swelling sits in and they can't move their hands, the tighter that joint's going to be. So if you're treating someone who has a lot of swelling in their hands, their knees, wherever, their ankle, which is preventing motion, but we got to get that joint moving, you can use manual lymphatic drainage to help make the lymphatic system work faster and harder to get that fluid moving. And it really does help, and we see good results in that. Open wounds, you can use this around open wounds to start seeing to decrease wound size, get to healing quicker. Like I said, just acute and chronic inflammation. It's good for rheumatoid arthritis. You're working over joints, so it does. It can help with that joint inflammation too. And then CRPS. So not only does it have like an analgesic effect to help with the pain, but it does also work on the autonomic and the parasympathetic nervous system to really calm it down. And this is really helpful for people with CRPS. So we went over what lymphedema is, what causes it. So now, how do we treat it? That's most important. Like I said in the beginning of this video, unfortunately, lymphedema I find is not treated as often as it really needs to be. So unfortunately, I don't really get people in that stage 1 very often. I get a lot in stage 2 and I get a lot in stage 3. And so recognizing what lymphedema is, from, just patient-wise, doctor-wise, anyone recognizing it, gets you into treatment earlier. Like anything else in the therapy world, the earlier you get treatment, the better your results are going to be. So getting treatment right away is really important too. And it's also on patients. Sometimes patients, their legs just swollen, their arms just swollen. They don't know why, and they never mention it to the doctor. To them, that's not pertinent. Or they're embarrassed by it, which is also really common. And so they kind of just choose to ignore the problem, or they don't want to talk about it because they're embarrassed that their leg is so huge and they don't know why. So it's really important that patients recognize what's going on. If you're having this swelling that's developing for no reason, that they need to get help and they need to get treatment. And that's where, someone who can do complete decongestive therapy and who's certified in it is really important. So complete decongestive therapy is the gold standard for treatment right now. For lymphedema, I did say earlier there was some medications, there's some surgeries, which some are effective, some aren't. It's a case-by-case basis a lot of times, but CDT is the gold standard for treatment. So CDT is composed of 4 parts: manual lymphatic drainage, skin care, compression, and therapeutic exercise. And it's divided into 2 stages. So the first stage is the intensive phase. This is done in clinic with a clinician or a therapist. So the goal in this phase is to decongest the lymph, get that fluid out. And this stage ends when you see measurements plateau. When you're not really getting results, they probably hit their max benefit at this time, and they need to be moved on to stage 2, which is the improvement phase or a maintenance phase. So this is self-management. This is done at home. They're not being seen in the clinic. The goal of this is on the patients. It's lifetime management, and it's to maintain and improve upon phase 1. With lymphedema patients, you're really going to see they're going to be recurring customers. They're going to get better. You're going to discharge them. They're going to go home. They feel great. They're doing the massage on themselves. They're doing the compression wrapping. And then either something might happen where they just have an increase in swelling, or like most people do, they get a little lazy with their HEP and they're not wearing their garment as often, or they're not really doing the massage and not using the pumps, and their arm gets swollen and they can't get it back in the sleeve you ordered them. So then they come back to therapy and you have to start over. So this will be a lifelong relationship you have with these patients, because they are going to need treatment over the years. So manual lymphatic drainage. This is the first part of CDT, and this is what I do for treatment. So this is a manual technique. It's done by the therapist, someone who's been certified in it. And what it is, it's just a very soft massage to move the lymphatic fluid from the area where it's congested and get it drained back into the heart. And when I say soft, I mean very soft. So it's not really getting in there and pressing deep and down like you would think you would need to. We say it's very similar, like if you were going to stroke a baby's forehead. That's as soft as it needs to be. And so what you're looking for, I'll kind of show it on me as good as I can. You're really just looking for that skin stretch. So you just want to see the skin move. That's as hard as you need to go. You don't need to press down into it. You don't want to press down into it. Just very soft skin stretch and then move to the heart. And this is done throughout different pathways, and the pathways and the sequence depends on where you're treating what's congested. So what this does, why we do it, is, for one, it stimulates lymph angiomotoricity. What that is the speed of which the lymph system is contracting and relaxing to move the fluid out. It mobilizes lymph fluid, so it gets that fluid moving, reroutes the fluid from congested areas to non-congested, like we talked about. We're moving all this stuff, all this fluid, like if it's in the arm, we're going to work on the chest, clear the chest, move it up the arm, and then move it to the unaffected area to get it out. It has a fibrinolytic effect, which means if you have fibrosis, it helps to really break it down. And it creates a suction effect. So the good thing about that is let's say you just have a really, really large arm. So the whole arm is swollen, maybe even to the chest. You can't treat all that in one day in a clinic. It's gonna, you have to break it up into parts. You really want to prioritize your time. So maybe just working on the top part of the arm. So you work on just the upper arm, you're going to see decrease in swelling in the lower arm because it suctions it up to bring it back. So you really are getting that full treatment even if you're not hands-on working on one area. And it also has an analgesic effect like we talked about. It's very soothing. It really helps with pain. So the mechanics of it. Like we said, it's a gentle massage that improves function and reroutes fluid from affected areas to non-affected areas in order to return to the heart. So there's multiple pathways. Like I said, the sequence all depends on what you're treating and where you're treating it and where you're trying to reroute it. And it's all based on the anatomy of the lymphatic system. And you should always treat the abdomen. Sometimes it does get neglected because you might not see swelling in the abdomen. But even if you don't see swelling there, you should at least do one day to clear it up. Clear the abdomen, just make sure it's not congested, and then move on to the area, let's say the arm. Because what happens is, let's say the abdomen's a little swollen, but you don't really address it, and you start moving fluid on the arm into the abdomen, well, now it's just going to sit there. So you really need to clear that area too, and I find that gets neglected a lot. So the skincare. Skincare is very important for patients with lymphedema. Once you have lymphedema, you're at a higher risk for infection and decreased healing. And this is due because now you have this diffusion distance. So we know when healing occurs, it's because you have those healing cells that come out of the vessels, make their way to the skin to cause, to help with healing. Well, what happens is when you have lymphedema, that skin, which maybe that distance was only about this thick, is now maybe that thick. So it's going to take a lot longer for those particles and those cells to get to the surface of the skin. So it's going to be an open area for longer. So increased chance of infection. The protein fluid is a very good breeding ground for bacteria. And you want to avoid any abrasions because it's going to reduce the lymphatic load on the lymphatic system. Anytime you cut yourself, your body heals through an inflammatory process, and we don't need to add any more inflammation to an already inflamed system. So it's really important to make sure you're doing good health skincare, and we're going to go over that. So some precautions that I give my patients are, and this is good to prevent lymphedema if you're at risk, and once you already have lymphedema. So avoiding skin abrasions. This is any kind of cut, anything to the skin. So if you're shaving, avoiding cutting the skin. If you have animals, keeping their nails cut short. Cooking, gardening, just wearing gloves. If you get your nails done, tell them not to go so aggressive on the cuticles, like they can do sometimes. You're avoiding any IVs or injections into the affected area, and avoiding blood pressure on the affected area. So let's say it's an arm, it all needs to be done on the other arm. And most doctors and nurses, anyone doing these, should know this, but it's also really important that you stand up for yourself and make sure they do not take it. I've had patients who develop lymphedema due to blood pressure being taken in the arm they had the mastectomy. Avoiding mosquito bites, keeping the skin clean and dry, but also keeping it very low moisturized with a low pH moisturizer, such as Eucerin, got the same pH as the skin, so it's just better for it. So compression. Compression is the second part that's really important with CDT. So this follows the main lymphatic drainage. So why this is important is because fluid's going to reaccumulate. Once you move it, it's not just gone, it's going to come back in. Like we said, it's chronic progressive. And the skin elasticity has been stretched out. So it's not just going to snap back all nice like we would want it to, unfortunately. So it's going to remain kind of loose so the fluid's got all this room to go. So you need some kind of compression to hold it in and to prevent that fluid from coming back. It reduces the filtrate, so it reduces how much is going to refill, increased reabsorption, so it increases how much is going to get picked up and returned. It provides support for the tissues, it breaks down fibrosis, so those patients who have a lot of fibrosis, the compression is what's going to break it down over that long term. And it's the most important aspect of lifetime management. Once you discharge them, if they never do the self-massage on their self, what you teach them, if they don't have a compression pump or they have one and they never use it, but they're doing compression every day and every night, they're going to be okay. It's when you neglect the compression part is when you start to see a recurrence. So there's different types, and I'm going to show you some examples of these. So this is a short stretch bandage. This is what we use in the clinic for wrapping in that first phase. This is where we wrap them their arm or their leg before they leave and they go home, and they bring it back and we wrap it. So what this is, like I said, short stretch. It looks like ACE bandage. It looks exactly like ACE bandage, but it works differently. So while ACE bandage has a high resting pressure or high resting load and a low working load, which just means that when you're resting, the ACE bandage isn't really compressing. No, I'm sorry. The ACE bandage has a high working, low resting. Back it. High resting, low working. So sorry. So high resting. So when you're resting, the ACE bandage is adding tons of compression. But when you're working, it's not really doing anything. This is the opposite. Short stretch has a high working, low resting. So when you're resting, it's not adding compression, but when you're moving, it's adding compression. And that's important because you're moving, those muscles are pumping. This is working with that muscle pump to really push out the fluid. So if you have compression pushing down and muscle pump pushing up, that fluid's getting squeezed and pushed out. So it's really important. So this is what we wrap them up in the clinic. But and they can wear this at night once you discharge them, but once they're discharged for home maintenance, they really need to be in a custom garment for them because this is hard to do. Wrap yourself, it's tedious, and it's just, they might not be able to do it or might not have someone who can do it for them. So they need to be in something that they can use easier because it's not easy for them, they're not going to do it, we know that. So there's a few options. So this is just a very basic compression garment. It's elastic and latex. It's got this little silicone holder on the top. And with this, you just slip it up your arm. They have them for the leg. It can go into the hand or it can be just at the wrist. This is just adds compression. It's a great low profile. Looks very natural. Comes in lots of colors. But this is a great option. It is hard to get on, so they do make different adaptive equipment that you can use to make this easier. But this doesn't work for everyone too. Like I said, it's really hard to get on. So if it's on your leg, mostly on your leg, if it's really hard to pull up, if you have arthritis, if it's just a large leg, this might not work for them. So that's when I really like these wraps. And there's a bunch of different compression garment companies, and they all have very similar products. They're just different for each company. All of them are good. It just kind of depends on what you're looking for. But most of them make these types of wraps. They're all a little bit different. But what it is, like I said, it's slipped on the legs. So it's really nice. It's cotton and there's a little bit of elastic. And you pull it to add the compression. So pull it around the area. This is really good for those who maybe can't pull it up or their hands hurt, so they don't have someone to do it. The limb's too big. This is a much easier way to do it. And then they make these which are great for nighttime wear. They're much softer. They're not quite as tight, but they still add compression. Good for nighttime wear. So those are just the different options you have for compression wrapping. You just want to talk to your patient and about their lifestyle and what's going to work best for them. Like I said, the best thing is what they'll wear. And no one wants to wear compression. You have to talk them into it, and you have to just educate them on the importance of why you need to be in compression. So then exercise. Exercise is the last component of it. It's also really important. It improves lymph transport. It increases venous return. It optimizes their muscle pump. And like I said, so you're wearing it with your compression bandage, and that increases the amount of lymphatic load that's being pushed out from the congested area. And these are really simple. If it's like your lower legs, just knee flexion extension, ankle pumps, if it's your arms, elbow flexion extension, finger pumps, anything just to get those muscles moving. They shouldn't be complex. Patients with lymphedema oftentimes have a more sedentary lifestyle, so it needs to be something that they're going to do. And that's really all I have. If you have any questions, you can just send them to us, and I'd be happy to answer them. Just really as important is recognizing lymphedema, getting treatment for it, and staying consistent with your treatment. All right, thank you.